identify them, and appropriate referrals to the surgical colleagues can be done to prevent the loss of limbs in these patients because of the any injuries. The neurological injuries, the GCS remains one of the important tool for not only the initial assessment but reassessment after the initial screening and management. Try to look for pupillary signs and letter-aging signs in these patients. Do have a frequent interval, specifically if you have done some interventions with regards to the airway, breathing and circulation management. Try to look for whether that was the major insult of hypoperfusion or hypoxemia to the brain leading to the neurological damage, to neurological injury to these patients. Do have a look on the spinal assessment, because it has been seen if for some reason patient is drowsy or the patient is being moved from one place to other, if there is any subtle injury to the spine, it can be precipitated during the subsequent management. So try to look for, if the patient is conscious, try to look for the tenderness in these patients, and try to look for the complete motor and sensory examination, including the reflexes. And if there is any doubt, you can have imaging studies. But if the patient is unresponsive, then you need to assume to have the spinal injuries in these patients and take all precautions so that their spine is stabilized for further assessment or management. Spine and spinal cord stability must be there in case if they are being moved, but remember that the assessment of spine should be done once the major life-threatening and potentially life-threatening injuries has been taken care of, because it has been seen that for the purpose of spinal injuries evaluation, the CT scanners or the imaging suits becomes a death zone for these patients, because they may take a lot of time to be moved from CT scanners and MRI, and hence they can decompensate at these places and leads to catastrophes. You also should be cautious about the neurological deterioration can happen during the movement or the transport of these patients, and hence you should be cautious while they are being shifted from one place to the other. These patients may require special diagnostic tests that will be based on the initial findings in the primary and secondary survey, and you can get it done. But remember, as I mentioned earlier, if you think that those diagnostic tests, the outcome will mandate our intervention which is not available at your place, do not delay the transfer for the purpose of diagnostic tools. Only if you have the facilities, for example, as I mentioned earlier, if you have the neurosurgical opinion, neurosurgeon available at your center, then only your CT scan needs to be done. If you think that neurosurgeon is not available, they should be shifted to the higher center where they will be evaluated according to their protocols, and you should not be wasting time shifting them to the other centers and waiting at your center for the various diagnostic tools. And also you should be very based on the mechanism of injury, very suspicious of the various missed injuries these patients, and these can be picked up with high index of suspicion, a thorough secondary survey of these patients, and then subsequently you can have various imaging modalities to identify these things. We also need to be considerate about the symptom management in these patients. Because of polytrauma, they will have a lot of pain because of bony injuries, musculoskeletal injuries and other organ injuries, and hence you should provide them pain relief. But remember that these patients, since they have polytrauma, you should be using whatever the drugs very cautiously, because for example, if a patient is having CNS trauma, the opiates can lead to an exaggerated response in them, and hence it has to be titrated, and they need assessment and reassessment to monitor these patients, so that if patients become drowsy or becomes overdose, you have the plan for managing these patients. The patient can also be, in a majority of time, any circulatory collapse is considered to be a hemorrhagic shock in these patients, and that's why you need to locate for the site of bleeding, and then you take a decision. And the FAST has become one of the very important screening tool, which is very important for patients of all trauma victims to identify the source of bleeding and subsequent management. And as I mentioned earlier, the chest X-ray and the pelvic X-ray is also the important aspect that needs to be done for these patients to identify major source of bleeding in the chest cavity or the pelvic cavity. And once you identify them, the majority of time the external bleed can be stopped by direct pressures, but then if they are having bleed at other places, then you need to have a specific interventions. Like for example, pelvic fractures may require angioembolizations, splenic ruptures, liver ruptures, kidney ruptures, retroperitoneal bleed will require operations if they remain hemodynamically unstable. And at times we also can give them a hemostatic agents for generalized ooze in these patients that will be taken care of. And in case if they are having pelvic fractures or long bone fractures, the pelvic binders or the splint would try to reduce bleeding in these patients till they can be optimized and then subsequently shifted for operative management. The transfer is important aspect. In case if the facilities are not available at a particular center, they need to be transferred. So any patients who has injuries which exceeds the institutional capabilities or the facilities available, these patients must be transferred to higher center where these facilities are available. And when the transfer should occur,
you need to wind up.
Right, sir. So these patients needs to be transferred, and during the transfer you should be very cautious about the airway and ventilatory control and also about the hemorrhage control in these patients. To summarize, any trauma victim that comes to us, you have to have a stepwise approach, looking for the life-threatening injuries first and then shifting to the potentially life-threatening injuries first. Do assess and reassess your patients at appropriate intervals and look for the response of your interventions that you have done so that these patients remain specialized. Thank you so much.
Thank you, Dr. Gar. And I guess you can have a just quick question from the audience, and then we'll wind up the session. And I can see a lot of people for the next session. Yeah, there is a question from the back, and we have a mic there.
Good morning, sir. So, like we are considering USG and everything in regarding to, sir, means major bleeding patients or having internal bleeding. Sir, what do you think about the role and what is the importance of tranexamic acid? Sir, is it very vital as it can be life-saving in these cases?
Yeah, so the role of tranexamic acid is increasing in these patients. So if you have generalized oozing from multiple places, you can give the dose of tranexamic acid, and there are sufficient evidence of its uses in the emergency setup. But remember, there are two aspects here. The tranexamic acid will not lead to the stoppage of major vessels bleed, right? For that, probably depending upon the site and the amount and the hemodynamic stability, you have to take a decision between conservative management versus operative management. Once it is operative management, patient has to be shifted to the operating room. Once you are thinking of conservative management, the role of tranexamic acid may be there. And even when they go for operating suite, because they will be identifying in a polytrauma victim, they could be bleed from major vessels, but they will be losing from various other aspects also. Then in those situations, you can give tranexamic acid intraoperatively also to these patients. But you should not only be relying in a patient of hemodynamic instability for conservative management with drugs only.
Thank you, sir. Sir, another one. Sir, a patient of hemorrhagic shock or RTA patient. Sir, apart from fluid resuscitation and resuscitation with blood products or colloids, sir, is there any role of, sir, using vasopressor in emergency?
Right. So we were usually talking about the hemostatic resuscitation. Earlier we used to say that give them boluses of fluid up to 2 liters, but now we are moving down, right? So we say give a 1 and 1.5 liters of fluid, because if you give them a lot of fluid, the plugs, the hemostatic plugs that are there at the bleeding sites, they will get dislodged, and the patient will again bleed, and there will be dilutional coagulopathies. So you can always start them on the crystalloids first as the primary line of management. And we were discussing about the blood management. In trauma victims, we usually say the fresh whole blood is one of the important aspects. But then the fresh whole blood means it has to be within 3 to 7 days. The definition is not very clear about it, but usually within 3 to 7 days collection, because after 3 days the platelets and other factors starts going down because of their shelf half-life. In this situation, when the things are being arranged, you can even start them on vasopressors for a moment. But this is not the definite management. This is management for the time buying, so that you can find the source of bleeding and correct it, and while maintaining the perfusion of the vital organs. And then subsequently identify the source, and depending whether you want conservative or you want definitive surgical control, decision needs to be taken up.
Sir, what would that ideal vasopressor be?
Usually the norepinephrine remains the drug of choice for managing in these patients for trauma victims, but I said it again, I repeat it again, this is not the primary treatment. Primary treatment remains the fluid and the surgical control of the bleeding. While this is being managed, you can start on these drugs.
Very, very thank you, sir.
Thank you, Dr. Garg. And with this, we come to the end of this masterclass session today. And I will hand it over to the organizers for the next session.